Healthcare technology is evolving faster than ever, but who's really driving change? I'm Zelcha Emanuel, healthcare IT strategist and founder of Amplify and ZE Health Tech, and I've spent over 20 years inside the nation's largest health system, seeing it firsthand. This is the Digital Dose, where I sit down with innovators and disruptors shaping the future for healthcare technologies. No buzzwords, just real talk about what's working, what's broken, and what's next. Let's get into it. Welcome, everyone, to the Digital Dose podcast. I'm really excited for today's conversation. I'm joined by Jeff Grant, the president and founder of Schedule F Healthcare Strategies. Jeff is a person who ran Healthcare.gov. He spent over 30 years as a leader in the federal healthcare space, most recently serving as an operations director and CCIO with CMS, where he held 600 federal staff and thousands of contractors powering the ACA marketplace that enrolled a record 24 million plus Americans. He's also led the rollout of the No Surprise Act. He is a 1989 Harry S. Truman Scholar, a retired Navy Reserve Senior Chief Petty Officer with 22 years of military service, and someone who describes himself as a healthcare change agent and solver of complex problems. Jeff, welcome to the show.
Thank you very much. It's great to be here.
Awesome. We are excited to have you. Jeff, your team at CCIO was responsible for running Healthcare.gov, the operations background of the ACA marketplace that enrolled a record 24.2 million Americans for the 2025 coverage alone. That's a staggering scale. Can you take us behind the curtain on what it actually takes to run a platform like Healthcare.gov? What does that operational reality look like when you're managing 600 plus federal staff, thousands of contractors, and millions of enrollment transactions?
It takes a village, right? It takes this big team and it takes a bunch of people that are unified around a common goal. So I always felt that my role at the top of the organization, and you learn this from the military, is defining very clearly the overall mission and then the very specific strategies and tactics that you're going to use to meet that mission, and then deploying the expertise that I personally didn't have on many of these things that it takes to pull this whole thing together, and letting them understand the direction you're going, commander's intent, as we would say in the military, and then letting them do what they do best, and then having them come back to you with solutions and ideas to advance the mission. And if you look at healthcare.gov very specifically, I think we're most famous for a very terrible launch in 2013. But what happens is, if you look at 24 million people in the end of the last administration getting enrolled, you realize we weren't the same healthcare.gov that launched. In fact, there was a very quick repair effort to make it usable for year one and to get as many people enrolled as possible. And then there was a very conscious effort to kind of just dig in and figure out what it took to have the first generation platform be stable. And then there was, before the end of the Obama administration, a reimagining of that platform to say, okay, this is really not the way we should have built healthcare.gov. We can only go so far with it. And rethinking what that platform is and streamlining it. And we spent probably the next 4 years doing that, basically taking it and layering the architecture. So we had a database layer, we had a great service layer, and then the web layer above that. Before, it was kind of all tangled up in a mass of code that was not particularly well designed. And when we got to that level, the next thing we could do then is optimize the service layer for optimal performance. Because if you want to get 24 million people through, or in the federal exchange, 19 million, set records on your last day and not have any decline in service, you need to optimize the service structure that sits between the website and the data layer so that everything runs super efficiently, and that's what we ended up doing was reducing response times, making the applications simpler to go through, reducing load on the system so that basically we could handle a peak workload without even blinking. We could lose an Amazon availability zone on the last day and we could still run. We were that good at that point. So we had hardened it to where we didn't have the failures that now you even see on commercial websites. Like you'll see Ticketmaster when Bruce Springsteen goes on tour come down. They have fewer people online buying Bruce Springsteen tickets than we had concurrent users on the last day of open enrollment. That is what we scaled to be able to do because that was a requirement as a government agency. And of course, Ticketmaster gets this one surge, and we have it for 10, 12 hours. We have that kind of load on the last day. And so, what we really did was have an entire strategy over 10 years to make everything run so well that we could serve people the way they expect to be served when they go to a website.
Wow. Phenomenal. You originally conceived Schedule F healthcare strategies with the intent to hire public health policy experts who would be expected to be terminated under the Schedule F executive order. But then the mission shifted dramatically when the DOGE-driven layoffs hit CMS. Can you talk about that pivot and what it was like to launch a company and immediately have the mission expand into something much more urgent?
Yes. So, there was a policy proposal under the previous Trump administration. Actually, it was a policy that was put in place and started to get implemented, but never was ever fully implemented within HHS or the Centers for Medicare and Medicaid Services, where I worked, CMS. But it was to take people that had career civil service protections, move them from the schedule that gave them that permission to a new career schedule that allowed at will firing. So you could not, as a political appointee, if you didn't like the person that was career working for you, if they weren't performing poorly, you could not just walk in and say, I don't want this person, fire them. This gave you the ability to move them to that schedule and say, I don't like their policy viewpoints, I don't like their politics, and move them and then fire them. So I was very concerned since they had done that in the last 6 months. It was part of Project 2025 to re-implement this. I was very concerned that they would do so. And by the way, they just finalized that rule this week. They've renamed it schedule policy slash career, but it took them a year to get the rule in place. And there was a regulation that the Biden administration put in place that prevented them from doing it.
Mhm.
So they've now re-regulated, put a rule in place that has given themselves at least the regulatory authority to do this. But meanwhile, a year has gone by and they wanted to downsize the government right away. So the first thing they did was go after the newest employees we had, the probationary employees. And so they sent out an order on February 13th. We'll never forget this because we called it the Valentine's Day Massacre because it all went down on February 14th. Um, they told us to fire every probationary employee we had. As background, a probationary employee is someone normally in their first year, but under certain programs, it can even be 2 or 3 years. I talked to a scientist that was the scientist appointment was a 3 year probationary period. This woman that I talked to in that case had 20 years in private sector science and was an expert in her field and had 2.5 years for the government, but was fired just arbitrarily because she was quote unquote on probation. Now, the probationary period is designed so that you can easily get rid of somebody that you've hired that doesn't work out. They just, you do your best job you can hiring, but some people just aren't a fit for the job. They don't match what they said in their resume and what they told you in their interview. They don't work as hard as you wanted them to. They don't take direction well. Whatever the situation is, you basically have a low bar to getting rid of them. It was not designed just to say you're an at will employee and we can fire you whenever you want, regardless of your performance. But anyway, at the time this happened, I had about 1/6 of my staff was subject to this firing. It was 86 people out of just over 600 people. And in CMS writ large, originally it was going to be about 400 people. They kept negotiating it down and negotiating it down. I think they maybe got it down to 150 to 200 people. But I had already announced my intention to retire because I had seen the writing on the wall and realized there was nothing I could do in my position to protect my people or my program. So I thought I would go outside to try to do that for the first time in my career, by the way. So I worked for Republicans and Democrats my entire career. Probably spent more time in Republican administrations than Democratic administrations, but this
Mhm.
was quite a different animal. And so I decided I would leave. And then when these folks got fired, one of the purposes of my business was to provide placement services for any CMS employee that was impacted by the change in administration. They themselves felt the need to leave. They took the fork in the road that Elon Musk offered. They got fired. They got riffed, what have you. We were there for folks. And we have now actually, just this week, finally got our resume count under 100. I think we have had a total of around 250 people that came to us for help, and now we have fewer than 100 left to try to get placed. But my mission is to continue to serve, now to serve the people that have been wrongfully displaced, as well as to kind of work in the consulting space. But without that kind of high level of expertise working for me, it's just kind of a solo deal right now rather than what I originally envisioned this to be.
Understood. Healthcare.gov had a famously rocky launch in 2013, but under your operational leadership, it became a platform that doubled enrollment from around 12 million to over 24 million in just a few years. For our audience of the healthcare technology leaders, what were the key operational and technical decisions that enabled that kind of scale? And what lessons from that transformation do you think are most transferable to other health tech platforms?
Well, I did kind of talk about going to the three-tier kind of architecture where we had the division of the layers, and then you could very carefully focus your efforts on each layer to optimize the performance there. We have a great web team. They actually worked for another office within CMS, the Office of Communication, that handles everything website related for CMS. But they optimized the application workflow, and by us designing services that they could leverage and call as needed, the kind of the interaction of those, they could optimize application workflow, we could optimize the service architecture underneath that. We also stabilized the databases, we migrated to the cloud, and we're able then to scale out and scale in, scale up, scale down, but mainly scale out and in as demand rose on the application. We became much more effective at uh, performance testing. So we learned lessons. We had some problems in 2019. And I will say, like, when I came in, I was told every year on the last day, maybe even the last couple of days, you're going to have what we call waiting rooms. So you will not be able to handle all the load at peak. So what will happen is people will hit the website. If the website is running hot, we'll shunt them off to a waiting room. They'll have to wait 30 seconds, a minute. Then they can get let in, and we will meter the number of people. And you can just expect that this is going to happen. Also, the call center won't be able to handle the call volume because you can't have enough trained call center reps to handle the very last day because of the surge in calls. Um, my goal was for both of those problems to be eliminated. They kind of magically disappeared for a few years. We had gotten pretty good, but then the year we moved in the cloud, there were so many changes, so much uncertainty that things went wrong on the very first day that we fixed right away. And then on the last day, we were very close to handling peak capacity. There were like three different things, all that went wrong. And if only one of those things hadn't gone wrong, we wouldn't have tipped over. But by all three going wrong at the same time, we tipped over by January. So the last day of open enrollment was December 15th. By early January, we were in a conference room with everybody going through exactly everything that happened, identified the three culprits by early January, and then went to work to make sure that never happened again. And it never did. I'm not saying things couldn't happen, but it was basically just rigorously doing lessons learned after every single open enrollment, and then having action items for everybody. Every single contractor that worked on that had action items to make it better each time. And we have done, by the way, since the very beginning, the guy that ran operations under me hosts a lesson learned, and everybody that works on healthcare.gov has to turn in things that went well and things that could have gone better, and the things that couldn't have gone better turn into action items. So you don't just say we had a successful year in 2020. You say
Mhm.
we had a successful year in 2020. It's going to be better in 21. And in 21, you say it's going to be better in 22, uh, because you can always be better. And I think the key is, um, this is something that I'm a big fan of the University of Michigan, and their basketball team is doing quite well this year. But one of the things their coach continually says is we have to have lessons learned off every win, because we don't want to have to lose to have a lesson learned. We want to win and then say what we can do better. And I think that's true in business. I think it's true in government. You want to keep winning and you want to keep improving. So you have to be very self reflective and willing to say, yeah, we won, but we could have done better. And it's never feeling bad about what you did either. I always told people you're not allowed to apologize for what you did, because every one of you did the best you could this year with what you were doing this year. Do better next year, and then do better the next year, and do better the next year, but never apologize for the year you had, because the year you had was great. Just don't be satisfied with it.
Absolutely. That's definitely a sentiment and a thought process that's going to spawn nothing but growth, and you're going to continue to get better if you have that thought process. With the mass layoffs at CMS and the departure of so many of the people who built and ran healthcare.gov, there's a real question about institutional knowledge. You said that the DOGE firings hit some of the most amazing staff that the CCIO team ever hired. What's your honest assessment of the risks of healthcare.gov operations and the millions of Americans who depend on it? And now that so much of that expertise has been removed.
So I will say my component, CCIO, that's how we actually say it. We used to be OCIO, it was
Okay.
OCIO, which made sense. And then we added a C and just said CCIO. But they stopped the firings with the probationary people for CCIO. So if you think about the people that built Healthcare.gov and had made it soar over my last, you know, 7.5 years there. And really, even before I was in that job, people were already working on making it better. I inherited a very good team and just had the pleasure to lead them. But those people are basically still there. It's been fairly normal levels of attrition in that space. They're very dedicated to it. The fact that they are allowed to do improvements has them very invested, because I think each one of them finds a pleasure in their job because they're allowed the creative freedom to identify opportunities to improve and do it. So we actually had very high retention rates. What we lost was, I think, more improvement opportunities, because we really felt that we were limited. We had hiring targeted around certain things. We hired a lot of folks to improve our data analytics, which
Mhm.
then can give you the kind of feedback that tells you how to run your operation better. So we felt like we had a real shortfall in that area. The people we had were really good. We didn't have enough of them.
Mhm.
And so we were bringing on more people that could identify those things, would then help us target improvements in either operations or policy or anything else, and could answer more questions that we felt where we were not getting answers to quickly enough. That opportunity is lost because we fired data scientists that were fabulous. Uh, I think what we lost, and in much of CMS, I think this is true. There are some places where ongoing operations are a little bit imperiled, but for the main programs, what they lost were people that were working on the future.
Mhm.
And, it's kind of the safe place to get rid of people because you don't impact current programs. If you look at other places in CMS, I got rid of a bunch of people from the what we call the duals office, the people that worked on policies and how you would take care of the population that is duly eligible for Medicare and Medicaid. You have an office that handles Medicaid, you have an office that handles Medicare. All of those people get their benefits. The duals office was there to say, like we said every year, we can do better.
Hmm.
Well, now we can't do better because so nobody's losing anything. They're losing the opportunity that is there that they could be better. The Office of Minority Health is another very key one. So there are a number of underserved populations in the United States. It could be women, it can be minorities, it can be people in rural areas. The Office of Minority Health just looked at subsegments of the population that because of where they were in life, they somehow were not getting the same level of service as maybe I am getting from the system. So my health is fine, and maybe your health or somebody else's health is not because of their poverty circumstances. They live in a rural area where there's access issues, any number of things. Um, those people aren't losing anything that they currently have. What they're losing is this opportunity to make their health better and to bring their health up to the level of everybody else's health. So I feel like this happens all over the place. And if you look at HHS on a large scale, you get rid of people at NIH.
Hmm.
Maybe you don't cure a cancer that you would have cured in 10 years. And now maybe it'll take you 25 years, but you don't know because you never knew when you don't have a date when that cancer cure is going to be found,
Hmm.
but you know it's been delayed now. And the same thing with CDC for things they do. It's things that happen in the future, but not ongoing services. So it's really, I think, I always look at my job as investing in the future. Like I try to not think of IT as an expenditure item, but as an investment item that we do this, we make it better and we save money. We actually prove the ability to do that, to like make things run more efficiently. Then you lower your infrastructure costs, you lower your support costs because people don't run into problems. They don't get stuck and call the call center. So I always looked at improvement as what government should be doing. And I think we just kind of did the opposite of what the Department of Government Efficiency said they would be doing. We got rid of all the things that would make government run more efficiently. And what we have left is the ability to kind of run the same thing year after year, which is, I think, selling the American people short.
Wow. You've built out four distinct service pillars at Schedule F: candidate placement, healthcare policy consulting, healthcare IT consulting, and CMS GovCon support. I was struck by the healthcare IT positioning where you say, we're not going to push our magic AI solution on you. As someone who ran one of the largest healthcare IT platforms in the country, what drove you to lead with that kind of transparency? And how does that message land with clients?
So I think, the hot thing, everybody wants to do AI. I'm not an AI programmer. And there's a niche for that, but that's not my niche, nor is it like I think everybody wants everything to be AI, and I don't think everything is AI. I think there is just some core IT that needs to be there. I've kind of right now combined my GovCon consulting with the health IT. So I'm not doing anything outside the government space, but I am working with a number of IT contractors that have or wish to have CMS contracts. And so when they're talking about solutioning, I'm helping them think about, like yesterday, I had a conversation very specifically with somebody that has an AI platform, but it then is going to need a data layer above that to do what CMS will want it to do. And so it's like talking about how you kind of again like a service isolation type thing where the AI does what it does, produces a data set, and then you produce a data layer that uses that data set. And then you can keep like that AI doing what it does best. And so I'm trying to help people that have different IT skill sets partner because this is what we did at Healthcare.gov. That was what we did really well is we had a whole bunch of IT contractors that had their own niche, but everything had to fit together. It all had to integrate, and everybody had needed to know their role, and they needed to know the big picture of what we were trying to get done and how what they were doing fit into that. Like if I'm working on something, how does it work with you to get like, and how do we build one unified product where your product and my product come together and work seamlessly so that we're achieving this bigger goal? And so that's what I see my role still as doing, is meeting with contractors, identifying what they do well, identifying partners that do other things well, be it operations or IT, and try to find a way to integrate people to deliver the best possible services to CMS, which will help them win the bid, but it will also mean my old agency is getting better service than it used to get because you're making better partnerships.
Phenomenal, phenomenal. You've described yourself as an entrepreneurial manager throughout your federal career, which is a really interesting phase for someone who spent decades inside government. Where did that entrepreneurial instinct come from? And how did you apply it inside the organization like CMS, where innovation can be notoriously difficult?
Well, so I started off kind of in regular fee for service Medicare. I was not doing a lot of entrepreneurial stuff, but I came to work on Bill Clinton's healthcare reform. So there was some new things going on, and I got myself into um, a voluntary effort to have a national provider ID, which is now a HIPAA standard, by the way. But at the time, there was no law that said there had to be one. So we were trying to say, well, we're going to build a national processing system. We need an identifier for that will be used throughout Medicare, a common
Mhm.
identifier for all the providers in Medicare. But why don't we get Medicaid agencies and the private sector also involved in this and say, like, if we built this, would you come? And could we all agree on a standard? And then everybody could start using this, kind of what we had been doing with claims. But there were still competing claim standards out there. There was a flat file national standard format, and there was the X12 delimited file format. And it took HIPAA for finally somebody to say, okay, everybody is going to have a standard provider ID. Everybody is going to have a standard claims format and stuff like that. But then I had moved out of that, and I got into the ground floor of the way that managed care is paid for. So I got to do a brand new implementation. We had to build new systems, and we could like think from the ground up and say, okay, how would you do this? What's the ideal way to do it? And we got to create it ourselves. And then Part D came along, and we had to do the same thing. We had to come up with the operations and payment policies and then the systems to support those for a brand new benefit. So I keep working on all these brand new things that nobody has rules for. So what you are working on is by its very nature change. And then I went to a startup company where we were starting new processes, trying to build out new services so that we could expand what we did for our clients, expand revenue. So again, I was in the creation mode of like, what service can we provide? How would we provide it? At times, I was writing the analytic code myself to set up a service delivery for a client. And then I came back and worked on the Affordable Care Act, all brand new again. So everything was kind of in this mode of constantly being involved in the new cutting edge thing. And the one thing I had identified that I felt we had not done well with Part D that I wanted to do better was with Part D, we hired a bunch of change agents. And then we started doing wash, rinse, repeat with the program. And that takes all the creativity away from a bunch of people that came in to create. And they either stop creating or they leave because they're bored. I was the kind that was going to leave because I was bored because I didn't want to do wash, rinse, repeat. So what I wanted to do coming out of our implementation of Healthcare.gov and the payment systems was to foster this continuous improvement process. And so when I moved into the Healthcare.gov seat, we were already in the kind of rebuilding phase, and we just kind of made change what everybody's job was. And
Mhm.
so we were able to take all these creative people, give them a lot of creative license. I would say half of what my staff did, at least half of what my staff did, was because they came up with the idea and they implemented it. There are some things, of course, you're in a political world. There are going to be things that are laws that are passed. There are going to be regulations. There's directions you get from your political leadership. There were things I wanted done that you're going to do the things that I want to see done. But a lot of what I would do is say, I want us to go in this direction. Tell me how we achieve this goal. And they came up with the projects. And so you're able to, like, you can hire energetic, creative people and continue to create. And you can do that in government. So I felt like we had a super energetic, super creative place. And we got the most out of our people because we let them design. I set the path, I let them design.
Okay. Beyond healthcare.gov, you led the implementation of Medicare Advantage Part D payments and the No Surprise Act. For our audience of healthcare technology leaders and innovators, what did leading those large scale implementations teach you about the gap between policy, intent, and operational reality?
Uh, well, I think we were very successful on Part D. We had some challenges right at startup again on the enrollment side of the house that I kind of chalk up to poor system management and poor testing. They were avoidable. They weren't avoided, and we paid for that. So we identified some key system performance problems only post launch, and it took us a couple years to address all of them. But overall, on the payment side that I was running, we knew what we wanted to get done. We got it done. I felt like we were able to, I felt really um, there's always bumps along the road in any implementation, but we reconciled on time. We had a very accurate payment reconciliation the first year, and that was a year and a half after the rocky launch. So I felt really good about what we were able to pull off there. Fast forward to the No Surprises Act. And first of all, we were not given adequate time to implement. No Surprises Act was part of a budget bill.
Mhm,
So in a budget bill, like No Surprises Act was scored to be a savings.
mhm,
The earlier you implement, the earlier in a budget window you realize those savings. So the more years of savings you have, and that allows you to spend those savings on other things in your budget bill because of the way the spending rules work. So you basically score it as savings and then use that for the other budget priorities you have. So that is how you get a bill like that through is people want to do something else. And so they all come together and agree on this as their savings measure. The problem was it wasn't doable in that time period. And so at that point in time, we were in an agile development methodology and everybody swore by minimum viable product. We had the collision of minimum viable product and unexpectedly large demand for the use of our system. So we kind of thought we were going to start with a very small launch and we could get away with a very minimum viable product. When your MVP is TM, then it is not actually viable. We ended up with a non-viable minimum product, and it was a big lesson learned of like don't but the problem was we had a launch date, we had to hit it. It was a legal launch date. People were entitled to these. It was for independent dispute resolution. And so then we just had to buckle down and say again, like we do every time you have a bad launch. This one we knew we didn't have what we needed. We just thought we were going to get so few cases it wouldn't matter. We were projecting 22,500 cases a year. I think CMS is getting about 1.5 million cases a year now, maybe two. So those are several degrees of magnitude different, and that makes a huge difference for startup. And then the other problem was an operational one that I think I had never, until we started trying to manage this, really adequately thought this through. And I probably should have taken a pause to say, what are the challenges we're going to have on the operational side? And I didn't even do that. But we were like, there are lots of things going on. And I'm not going to, again, apologize for it because I think we got a lot right. But the one thing I was blind to is this is truly independent dispute resolution. There are 13 entities that we approve to do it, but they are not under contract to CMS. CMS does not pay them. And so when demand surged, if that happened and it was a CMS contractor, we would just throw money at the problem and say, okay, we're going to hire people. We're going to like throw money at the system or whatever, we do whatever we need to do. They needed more people, but they're making independent decisions as to how many people they can hire based on how much they're charging per case. Are they charging enough to support bringing these new employees in? Because these are all private sector for profit businesses making business decisions about how many employees they have. And they were building up huge backlogs, and I couldn't direct them to hire. I could just tell them that they needed to work the backlog or we were going to quit sending them cases. But we couldn't shut down 13 entities because then nobody would be handling these cases. We would just have a big backlog and we'd be failing to do our jobs. So that was like, that's a complexity I've never had to deal with. It's a fascinating model. We learned how to deal with it. We learned how to have these conversations and agree on strategies because we all, again, it's like getting on board instead of yelling at them. It was again saying, we're all in this together. What are you going to do? Like, what is your strategy for working through your backlog? And let's set up some targets. Let's like set up a game plan. Let's set numerical targets that we want to hit in terms of cases we're going to work per month. And let's set a trajectory to improve the case rate until we can start decreasing this backlog. And we did that successfully with every IDRE. But I would say it took us quite a long time to get there, understand how challenging that was, and to have the kind of conversations we needed to have to succeed. But I think I'm really proud of what that team has been able to pull off because it's one of the bigger challenges that CMS faced. Again, trying to do a new operation that nobody in my mind has done at that kind of scale in government and
Mm,
trying to figure out how to work it at scale. And the fact that they can do that now is truly amazing to me.
absolutely. You recently spoke at AHIP on building effective relationships with CMS leadership, and you've been featured on multiple podcasts discussing the federal transition. You're clearly in high demand as a voice in the space. Looking ahead 12 to 18 months, what does the next chapter look like for Schedule F healthcare strategies? And what signals are you watching most closely in the federal healthcare landscape?
Well, I think Schedule F, I don't want to build and take over the world. I would like to probably work more in the health plan space. And so thinking about how to get out of just doing a lot of government contractor support, but to help support health plans, understand what's going on with the CMS changes, how to work with CMS effectively where they're having struggles and stuff. I think I will probably try to move more conscientiously into that space. I think this year started out again, every startup is a challenge, right? So you decide in any startup, what are you doing first? What is your highest priority? My highest priority was placing people. And I still have people in the government contracting community that come up to me and say, well, are you ready to do consulting yet? Like, I've been doing consulting now for like 7, 8 months, but I don't go out in mass market. So it's kind of, I have a decent sized business and it continues to grow. So I'm not actually wanting to, like, as a sole proprietorship and the only consultant in the like company right now, I'm not looking for massive growth. I'd like to grow at a rate that I can control, where I can, as a retiree with 4 grandkids, I want to get grandkid time and some national park touring time and things like that. So I'm not trying to work 80 hours a week, and I want to make sure that I don't end up in that space. But I do want to stay involved. I think if you look forward at the landscape, the HR1 is going to hit with different provisions. It hits Medicaid and ACA pretty hard, especially by the time you get to 2028. So I think what I'm very concerned about is enrollment levels right now. The tax credits are already gone, the enhanced tax credits, and I think we will see an attrition there. And then the latest payment notice just came out from CCIO this week. There are a bunch of barriers to people getting enrolled that will continue to drive down ACA enrollment. So, this huge success we had of 24 million people, I'm very concerned that we're looking at 10 to 12 million people will be back at early years of ACA coverage levels, which is harmful to America. That means you're going to have 12, 13, 14 million people uninsured that were currently insured. The same thing's going to happen in the Medicaid space. So we could be looking at like a 25 million uninsured crisis and not realizing once again the goals of the Affordable Care Act to narrow that uninsured gap. So trying to think about what I can do in that space to advocate and try to educate people that may not be aware, because I think most Americans don't know how these programs work. They see something like one big beautiful bill and it sounds great. I got like $500 on my tax return, but they don't realize the harm it's doing on their neighbors and to their overall system. Like, you're you're going to pay for it in your own insurance rates if you have 25 million uninsured people who then will show up at emergency rooms for uncompensated care. It's going to cost those of us that are insured more money, which was the logic of the ACA, is get everybody insured so the people that are insured are not paying for uninsured people. and they can get regular care instead of going to the emergency room. So I think that's kind of my big concern is coverage loss. I'm not as worried about Medicare because they are covered. So no matter what they do with Medicare Advantage and traditional Medicare, there will be a program there. They all will get their bills paid. I'm more concerned about the Medicaid and private insurance market space.
Absolutely. Last one. You're a Truman Scholar, a retired Navy senior chief, and you've written, thought pieces on leadership lessons from the military training and even from the musical entrepreneurship of Paul Simon. If you had to distill all of that into one leadership principle that's guided you through every chapter from running healthcare.gov to launching your own company, what would it be?
I think what I've always tried to have in anything I work on is, well, like, do audacious things and be unafraid to do audacious things, even if you don't know what you're doing. And I will say, Paul Simon did that, like with the thing you read on Graceland, going to South Africa, recording a bunch of musicians with an idea that this will all fit into a song, but then bringing it back to a studio in New York and turning it into music, taking these recordings and turning it into a music that turns out to be possibly his best album. And it Nobody does it like that. And he had not done it like that. He was just going into new territory and trusting that it will work. And every implementation I've ever done, you have to have this trust that at the end it will work. And
Mhm.
you are going to the guy that started Pixar had what is I can't remember the name of his book. It's a wonderful book about Creativity Inc. Um, but he talks about the process of making even a movie, and when you're in this creative process, at some point in time, you're in this dark tunnel,
Mm.
and you cannot see the end of the tunnel. But you have to, like, you just have to have this leap of faith that the tunnel does come to an end and it's going to be bright and beautiful at the end of that tunnel. But there are periods of time when you're in that darkness. So you have to have this vision of where you're going. You have to believe you can get there. You have to do what it takes to get there. So
Mhm.
there's no, and you have to accept the fact that, like, when you're on the way, you're going to get a lot of things wrong, so you just rework, rework, rework until you reach that beautiful end of the tunnel. But it's always there, and you have to believe it's there. For me this week, it was finding out that 40 people that we had in our resume database, my office operations manager went in and checked every person's LinkedIn profile and found 40 people that had gotten jobs that we didn't know had gotten jobs, which is great. But we started this adventure. I've not done placement services before, and I started a company. And what is I was going to start it with all the things I knew how to do. Instead, I started with the thing I didn't know how to do because it needed to be done. It's a big, audacious thing to try to get done. And I told somebody earlier this week, they're like, you can't get every one of these people hired. I was like, but that's my goal. I'm like, I'm not done until everybody has a job. So, like, I don't like, if I believe and can't, then I'm selling everybody short and I'm selling myself short. So you can't believe and can't. You have to believe anything is possible. And if you believe anything is possible, then you're freeing yourself to do whatever you want to do.
Touche. Jeff, thank you so much for sharing your insights and your story. This was of an incredible value. I really appreciated your time, your openness, and the work you're doing to support the people who dedicated their careers to public health. So, thank you so much for being a part of the Digital Dose podcast.
Thank you for having me. I really appreciate the conversation.